Welcome to RUMC Connections. Welcome to RUMC Connections. I'm your host, Meredith Gaskins. On RUMC Connections, we often focus on what people can do before a medical emergency happens. Today, we're taking you inside one of the most critical emergencies there is and what happens after. When a stroke begins, the brain immediately grows into crisis. With each passing minute, millions of brain cells are at risk. That's why specialists often say, time is brain. At Richmond University Medical Center, stroke patients are met with rapid evaluation, advanced imaging, and around-the-clock neurological expertise, care that can dramatically change outcomes and preserve quality of life. But what happens after the emergency? What does stroke treatment really look like behind the hospital doors? And what should patients and families realistically expect during recovery? Chief of the Department of Neurology, Medical Director of RUMC Stroke, and immediate past president of New York State Neurological Society, Dr. Allan Perel, joins us again to walk us through what happens minute by minute during a stroke, how fast treatment can make a life-changing difference, and what recovery truly looks like, from rehabilitation to regaining independence. At RUMC, patients also have access to the only stroke support group on Staten Island, which brings survivors and caregivers together to share experiences, ask questions, and support one another through recovery. This is an essential conversation for patients, caregivers, and anyone who wants to be prepared, because when it comes to stroke, knowing what to do can make all the difference. So thank you for joining me once again.
Thank you for having me on your wonderful show. Thank you.
When someone is having a stroke, what is literally happening inside the brain?
What's happening is the brain's not getting enough oxygen.
Okay.
The most common cause of it is that there's not enough blood supply because one of the vessels, blood vessels, which is like a pipe, closes off.
Okay.
It can close off because there's a thrombus, or like a plaque that's narrowing the amount of blood supply.
Mm-hmm.
It can close off because of an embolism, which means something from another part, like the heart, breaks off and lodges in that artery.
Yeah.
And it can even be from someone who has not enough blood sugar in their body. So their glucose is low, they took too much insulin, and the sugar is so low that the brain, although it's getting blood, is not getting enough sugar.
Okay.
The brain needs two things from the whole body, sugar and oxygen. So either one of those things can cause a stroke.
Okay. Wow, I didn't know that about the sugar. Interesting. Okay, so why do neurologists say time is brain, and what happens if treatment is delayed?
For every minute that a part of the brain doesn't get any blood supply, you lose 2 million cells, 2 million brain cells.
That's a lot.
And there are a lot of brain cells.
Yeah.
So thank God a lot of people make good recoveries after stroke. But those are lost forever.
Okay.
And each of those brain cells connect to hundreds or now thousands to other brain cells. That whole process really gets affected with a stroke. You can't go from one signal from, say, the left side of my brain to my right finger.
Yeah.
It doesn't work. So it has to go a different route, and it goes slower. It's clumsier. So instead of me being able to do this quickly, I do it slowly.
Yeah.
I have increased tone or stiffness, and that's what causes the deficits in people who have stroke.
Got it. Okay. Let's talk myth busting a little bit. So what would you say are some of the biggest myths that you might hear when it comes to stroke?
Number one, people are shocked that it occurs in people of all ages. Everybody thinks this happens on only elderly people. The idea that it happens in younger people is shocking. There was a person who we just took care of in the hospital who was in his 20s, came back from a long airplane ride, had a stroke. And we're still trying to figure out exactly what caused it, but it can happen in younger people.
Yeah.
People with sickle cell disease. There are a number of reasons it can happen in younger people. People with various forms of lupus, or what's called collagen vasculars, or rheumatological disorders. There's a lot of reasons that it can occur. People who have congenital heart problems. So there's a lot of good, well-known reasons that people can have a stroke even at an early age.
Yeah.
About 10% of people have strokes all strokes occur before the age of 45. And stroke right now, I think, is the number one cause of disability in the world. And it's the number 6 or 7 cause of death in the United States.
Wow. What is it about rheumatic patients that causes strokes?
It causes inflammation of the blood vessels.
Okay.
things like COVID and when COVID-19 back in 2020,
Yeah.
it caused a lot of inflammation, and that causes blood vessels when they're irritated and inflamed to close off.
Okay.
And that causes spasm of the arteries. So that's what causes it in
So
those
that
patients
inflammation.
with rheumatoid.
Got it.
And they also have something called fancy word called antiphospholipid antibody.
Oh, wow.
It's something that makes your blood clot more.
Okay.
So there's a reason that it happens.
Got it. Are there any other myths you'd see?
I think the other myth is something that we talked about before, that your brain hurts. You have to come in with a headache to have a stroke.
Yeah.
You don't.
Okay.
The brain, doesn't hurt. You could touch the brain and it won't hurt. What actually hurts are the covering of the brain and the sinuses. If any one of us has had a sinus infection, you know how much pain you have.
Yes.
The covering of the brain hurts. So if someone has bleeding in the brain, it causes that covering to swell or get pushed. But the brain itself doesn't.
Okay.
So very few patients will come in saying, ouch, my brain hurts, I think I had a stroke.
Yeah.
So that's an important part with that also. There's also the idea that is there treatment for stroke? People think there's nothing you can do.
Okay.
And neurology and stroke care is about 20 years behind heart care. Bypass surgery, various kinds of angioplasties, opening up the arteries, various thrombolytics, came out about 20 to 25 years before this worked for stroke.
Wow.
Because techniques had to change, the catheters had to be made smaller, the way we do things a little bit differently. But cardiology was ahead of us.
Yeah.
The heart doctors were able to do much more.
Okay.
Now neurology is catching up, and we have treatments that within the first 3 to 4.5 hours, and even up to, we can use clot busters or what's called thrombolytic agents in the emergency room as long as you get there. And you have up to a day or even a little bit beyond a day to get rid of what's called a large vessel occlusion. If you're having an active stroke and one blood vessel is large and it's blocked, we can take that out. And you can ask, well, how would you live if you have it? It's called collaterals. There are other blood vessels that go around it and feed it.
Okay.
They don't do as good a job, but they can keep the brain viable and living for a lot longer. So there's a lot we could do now that we didn't do before. Our holy grail, and this is something that we're all looking for, is some agent to give someone early on to protect the brain while this is going on.
Oh.
So in a number of agents we've tried, it hasn't worked yet. They
Okay.
worked very well in animal models, but not people yet, where you can give something that will make the brain's metabolic rate go down, be less susceptible to lack of oxygen, as we said a few minutes ago, and give you a longer period of time to get people better. And they're looking for that right now for EMS. If you have an ambulance in the ambulance department, there's actually a test in Brooklyn where an ambulance has a CAT scan on the ambulance itself.
Wow, just for stroke.
Just for stroke, just to see if they can get people done faster. In LA they have it, and I think Cincinnati, where they're having actually ambulances set up that way. I think in Mount Sinai in Manhattan is doing that too.
Wow.
Now, do we need that? I don't know. But they're able to give medicines earlier.
Okay.
If our patients get to the hospital, at our hospital at RUMC, where we both work, the idea patients get to the emergency room quickly. They get to CAT scan barely before I could see them.
Wow.
Within minutes, the CAT scan machine is in the same area as the emergency room. They're in the CAT scan machine within 5 to 10 minutes.
Wow.
So we get those answers very, very quickly. So I'm very happy with that part. I'm not sure we need a CAT scan machine on the ambulance, but it sort of just gives us an idea of how important it is for an early diagnosis.
Okay. Well, it seems like there's, some interesting things that could be on the horizon for stroke care.
Yes.
Perfect. So what would you say is the biggest mistake people make in the first few minutes of a suspected stroke?
Dismissing it.
Just dismissing
Not
it.
not that other people shouldn't worry about it. Shouldn't worry about them. There's certain things you can not tell someone and certain things you can't. If someone has slurred speech, I get this all the time where a patient is talking to a relative in California and has slurred speech. The person in California will call 911 in New York to go to the house.
Yeah.
Your speech is so important, and it's so unique to you. And even if you're slightly off, your family will notice it, your friends will notice it.
Definitely.
If you can't move your left arm that well, or your right arm, or your legs, or you have numbness, nobody's going to know except for you. And maybe they could see it if you're not walking well and you fall down. But short of that, you're the one who has to make that decision. So you really do have to seek attention when you have any of those symptoms.
Don't ignore them. Okay. What information would you say helps emergency teams act faster when someone calls 911? I'm assuming they should relay these issues so that they know it's a stroke and possible stroke.
The Fire Department of New York, FDNY, EMS, are on top of it. They know what words people use.
Okay.
They will say blurred vision, weakness, numbness. We get a call before someone even gets to the emergency room.
Wow, to let you
It's
know
called
that
a
they're coming.
pre-notification. And the emergency room is set up. And there was a time when I was a resident a number of years ago where people would sit in the emergency room with a stroke and be in the waiting room. There's not much they could do. They would just sit there. Now they go to the front of the line.
Yeah.
They go to the front of the line. People with heart attacks go to the front of the line.
Have to.
They're right in front. They come right in. They do not wait. They go for their CAT scan, as I said, immediately. And there's a stroke team that's called. There's
Yes.
a neurologist.
Yeah.
There's all the people in the emergency room. There's an interventionalist. And with technology, we can all look at the CAT scan in real time.
Yeah.
CAT scan is the picture we're going to get of the brain. So in real time, we see it. Everybody's looking at it on their phone or on their computer, and basically are able to then converse with each other about what we're going to do about this patient. And there are choices. Sometimes you just watch someone.
Yeah.
It could be a small stroke. It doesn't look, there's no large vessel disease. Person is looking okay. They maybe have gotten better. And there's nothing really to do.
Yeah.
But sometimes we have to make interventions, whether it's clot busters, thrombolytics, or thrombectomy, pulling the clot out. And we have all the capability to do it.
Yes.
We've got neurosurgeons on staff if there's any complications or people are bleeding. So we're able to really give a full array of treatment that any place in the country does for patients who are having a stroke.
Absolutely. It's honestly probably the most frequent overhead announcement that I hear when I'm in the hospital is stroke team report to the emergency room. They're so fast acting, but I think it's the most frequent one that I hear.
And it makes you very popular when you have a beeper. I take out this beeper, which I have, and to cover the hospital.
Yeah.
And basically people say, you have a beeper.
Paid you.
Right. People haven't seen beepers in many years. So there's a lot of ideas what people who used to carry beepers, but now I just carry a beeper around. And
Inefficient way to ding you.
They're able to reach me anytime, anywhere.
Perfect. Okay. What does the hospital stroke response look like behind the scenes when a patient comes to the ER?
Emergency room, they come right in.
Yep.
The emergency room doctor goes there. The nurse goes there, puts an intravenous line in,
Okay.
draws some blood, takes a quick look at the patient, makes sure that they're breathing okay, that their blood pressure is stable, that this is not something that has to be addressed first in a life-threatening condition. Patient immediately goes to CAT scan. The CT scan or the picture of the brain gets done. Patient comes back about 20 minutes later with that all done. We have the results, as I said, very quickly because everyone's looking at the results at the same time.
Yeah.
A decision is made what to do, and then the patient is in the emergency room and eventually goes to a regular medical floor.
Got it. Okay. What would you say are some misconceptions that people might have about stroke treatment once they reach the hospital?
People do something that's not really right. If someone has thinking they have a stroke or a heart attack, the first thing that they do, they go to their medicine cabinet and take a couple of aspirin. Now, in a majority of the cases, they get away with it. But about 10 to 15% of patients who have stroke-like symptoms, and you can't tell, actually have some bleeding in the brain. So there's two kinds of strokes. There's strokes where we use a pipe. A pipe closes off, and there's not enough blood supply, and you get a stroke, which is an infarction or a scar or area of dead tissue. What else could happen to a pipe? If it closes off, it could pop. And that causes bleeding.
Okay.
And bleeding in the brain, the worst thing you could do, because aspirin is what's called an antiplatelet agent. It makes platelets stick together to clot. So if I'm giving you, take a medicine that makes the blood thinner and you're having a hemorrhage, which occurs, as I said, about 15% of the time, I'm actually doing more damage. So I might have to do things to make you clot better.
Yeah.
So don't take the aspirin.
Okay.
You're going to get to the hospital 5 minutes, 10 minutes. We're going to have you in CAT scan. We will make the decision based on the CAT scan within 30 minutes. You don't need to take the aspirin.
Okay.
Because so many of my patients are very proud
Yeah.
that they took their aspirin.
Oh, boy.
And as I said, about 80% of the time they're right.
Yeah.
But they don't see the times when they're not right, where it becomes a much more difficult case, with more morbidity or more disability because of the aspirin.
What about something like a Tylenol or an ibuprofen?
Ibuprofen is a blood thinner also.
Okay.
But it has the same antiplatelet therapy effect. It just lasts a little bit differently. Aspirin will last for 10 days. Ibuprofen will last for about 4 or 5 days. Tylenol you could take.
Okay. Got it. Good to know. Because sometimes people think, if they, maybe if I just take this, it'll make it go away. So it's,
Yes.
Okay, good to know. How do neurologists decide which treatment approach is best in the moment?
Basically, it's time, how much brain is involved. So if someone's had a very mild stroke, they just come in with some numbness from their left arm and left leg.
Yeah.
Minimal. They're walking, they're talking, they're fine. Very rarely will we give these thrombolytic agents, these blood clot busters, because the risk is about 6 to 7% of having bleeding in the brain. Because I'm giving you something that's dissolving a clot. If I give that to you, sometimes I can cause bleeding. Yeah. That's sort of what it's doing. It's freeing up the blood flow.
Okay.
So that's why in very minor strokes, we don't. Sad to say, if someone has a very, very large stroke, we also sometimes don't do it either because the risk of bleeding is just so high.
Okay.
We still try to be very aggressive with our therapies, but somebody who's come in with a very large stroke, sometimes it doesn't work. So it's that middle. Yeah. It's that sweet spot between having mild deficits and major deficits, but not huge, where these medicines all do come in. So if someone, and it's interesting because there's a lot of thoughts about what's the most important part of your being. That's why I became a neurologist, because sort of your being is in your brain.
Yeah.
Is the idea about your speech. So you could have no weakness at all, but if you can talk, we'll always give you the medicine.
Yeah.
Even though all the scores don't show that much, because it's hard to live without speaking well.
Yeah.
Because it's your language, it's yourself, it's your essence in a sense.
Of course.
It's being able to understand and be able to talk.
Yeah.
So we're a little bit more aggressive with speech problems. So if you have slurred speech, we're always going to be more aggressive than even with someone with weakness. And you asked me before about TIAs, transient ischemic attack. Those are transient, temporary events where the blood supply was cut off for a short period of time. Now, if someone has a TIA, it's the same as a stroke with regard to the prognosis. People have a high risk of having another episode, short-term and long-term, after a TIA or a minor stroke. So this is something that has to be addressed very, very quickly. And people will always like to be told they have a TIA compared to a stroke. Yeah. It means, well, it just went away. And a lot of times people with even though clinically they got better, they went back, they had some slurred speech, they're back to normal. You get an MRI on them, you see a tiny or small stroke. Okay. So stroke is really small stroke, mini stroke, TIAs are really all the same word. But we do treat them, and the secondary prevention, once you've had them, are the blood thinners. And we use drugs like aspirin, very commonly. There's a drug called clopidogrel, which is a stronger antiplatelet agent, another kind we use together. And there's been a study that using both together for the first 21 days helps reduce the risk. And using a high dose of one of the statins, a drug called Lipitor or Torvastatin, Crestor, Rovastatin, they're just different names for it, are all high-potency statins that actually have shown to reduce the risk of stroke even more than just the cholesterol. They're really anti-inflammatory drugs too. Okay. So those are the big things we do as intervention. And then there's the workup. We get an MRI to see if there is a stroke. We do an echocardiogram to see if there's a clot there. We get blood work to see what your cholesterol looks like. So we're trying to get the whole picture and do this entire workup in a relatively short period of time. Yeah. Wow. Okay. And what would you say has changed technology-wise with how quickly or accurately you're able to treat strokes? The CAT scan we can get done very quickly. CT scans used to be, when I was in medical school, there were like 4 CAT scans in all of Brooklyn. I went to medical school at downstate in Brooklyn. Yeah. Now there are CAT scans everywhere. Then MRIs became popular in the 1980s, 90s, and now we have MRIs everywhere. So the idea of getting the technology to the patient, or the patient actually to the test, is much easier right now. Yeah. We're doing better with technology, so we can get pictures, and even the idea of how we get the clots out. These are every year they change the kinds of tubes that they use, the kind of filters that they use, suctioning, everything that they do has gotten better to reduce the risk. So to reduce the risk of a stroke, to reduce the risk of any complication from these procedures. Smaller needles, not as much of a puncture, you don't have to get as much bleeding in the groin area. So there's a lot of things that are being done that people don't know. Just the idea of the different kinds of things, the different stents, the different devices that we use have really changed dramatically, and they do change year to year because they always get a little bit better. I don't know what the odds were in the past, but how likely is
a patient to have another stroke?
With all comers,
Okay.
the risks is about 30 to 40% in the next 2 years.
Okay. But being on the proper medications and lowering things like cholesterol and all of that, I'm sure help reduce the risk of having another one.
And think about the medicines. When I was in my training, all we had was aspirin. So what would you do if someone had a stroke? You give them a baby aspirin. What if they had another stroke 6 months later? You give them a full aspirin.
Yeah.
What happens if they had another stroke 6 months later? You give them 2 aspirin. You could do this. You can go on for 2 or 3 years with how much aspirin to give.
Wow.
Now with our better medicines,
Yeah.
we have a much better chance of treating.
Okay.
And we always do want to treat the underlying process.
Yeah.
Atrial fibrillation is a big deal. There's irregular heartbeat. Everybody's wearing an Apple Watch. Everybody's doing different things to watch their heart rate. They're seeing if they have this entity called atrial fibrillation. And that's a big deal. Atrial fibrillation means that the atrium, or the top of the heart, is quivering rather than pulsating. So it's quivering. Blood in an area like that will start clotting. And those clots, if you go down and then they get pumped out by the big part of the heart called the ventricle, basically can cause a stroke. So it increases the risk of stroke 5 times more than with the people who don't have it. And treating it with blood thinners, and those are other medicines you might have heard of, Coumadin, Eliquis, very commonly used, Xarelto. So there are a number of agents that are being used right now to help that. And I think our recognition of that, in addition to blood pressure control, has really helped dramatically in reducing stroke risk.
Do you see patients coming in referencing maybe that they had no symptoms, but their watch alerted them and picked things up?
Yes, we see that at the hospital all the time.
Yeah.
More of the cardiologist, because that's really the heart rhythm. But we see these people all the time, and so many people who've had a stroke. The first EKG, we put them on a monitor, so we listen. They have atrial fibrillation. We could see it.
And you could be asymptomatic with that, but the watch could pick it up.
And
right?
we asked them, have you ever had this? No.
Yeah.
That's where getting the technology has really moved us so much forward.
It's very cool. Yes, absolutely.
Yes.
Very helpful. Okay. So people, often confuse stroke symptoms with heart attacks. So why is that dangerous, and how can they tell the difference?
Different parts of the body, but really the same process. An artery to the heart gets closed off with either a plaque or something that breaks off in there, a piece of cholesterol or what's called platelet plaque, and basically blocks the blood flow to part of the heart. And when that part of the heart doesn't get enough oxygen, basically it dies. Infarction just means dies.
Okay.
Same mechanism with the brain. Interestingly enough, patients with heart attacks, about 1% of people who come with a heart attack also have a stroke at the same time. And also vice versa, about 1 to 2% of people who've had a stroke are having a heart attack at the same time. So they really do go together. And these are arteries that get narrow. I mean, there are esoteric causes of stroke. You could actually have your veins, which drain blood, blocked. And you can get a backflow. It's called a venous stroke.
Wow.
You can get a stroke of your spinal cord. So it's not always just the brain, where you can't move afterwards, and that occurs a lot of times with atrial fibrillation. So these clots go off, and when they're breaking up, nobody knows where they're going to go.
Wow.
They can go to your kidney, they can go to your abdomen, your liver, they can go anywhere, and they can cause people to become paralyzed from a spinal cord process.
Wow.
So you can get strokes of the spinal cord. We don't think about it; they're more of a rarity. But you can get strokes because the blood going in is blocked, or the blood going out is blocked.
I never knew that. Wow. Okay. What do family members often do or fail to do that can unintentionally slow down care?
The idea is don't worry about it. You say, I have some numbness in my arm. Well, it'll go away. You must have slept on it wrong, or you're stressed. Whatever reason you can come, it just that type of day. You were playing ball that day. You can make up 100 reasons
why experiencing that.
And the worst thing is to go to sleep. If you go to sleep and hope that you wake up in the morning, you really take out the window of time that people could do well. Interesting, when you mentioned families, I thought you were going to say, what do they do? They ask very early on how someone is going to do. And the first 24 to 48 hours are crucial. Most times, we don't know how someone is going to do. The stroke could get bigger. Because even with our aspirin therapies or our blood thinners, even with some of the clot busters, sometimes it doesn't always work. So that first 24 to 48 hours are crucial. That's why you need to be in the hospital. People always want to run out of the hospital. And again, it's always people we want everyone to be home.
Of course.
But you need them in the hospital for at least that 24 to 48-hour period to do all these tests, because we're going to get MRIs, heart tests. Can't get them done as easily as an outpatient. You have to get authorizations. It takes a while.
Of course.
But here, getting it done in the hospital is crucial.
Yeah.
The thing also is that in the hospital, we're able to watch you. We do something in the hospital called permissive hypertension, which is a very funky way of thinking about it.
Okay.
High blood pressure causes stroke.
Yeah.
But if you've had a stroke, we don't want your blood pressure to be too low, because you're someone who's chronically had high blood pressure, and in you, just going down to normal blood pressure doesn't perfuse or doesn't give enough blood supply to certain parts of the brain. So we try to keep you on the higher end of normal.
Okay.
Which is so counterintuitive.
Yeah.
But if you think about it, I'm just pushing a little bit more blood there to get to the spots that we need.
Yeah.
And we do that for up to 5 to 7 days in certain people who
Oh,
have
wow.
larger strokes.
Okay.
We need to get their
The blood
keep that
flow, yeah.
perfusion. So we keep their fluids up. We even cut back on some of their blood pressure medicines to go higher.
Just
Interestingly enough, some people come into the hospital with extremely, extremely high blood pressures. 250, 280 is the top number. And those people, we always get them down.
Okay.
Because those people, if you're too high, you're not getting enough perfusion. Even though we said you want higher, you need sort of enough that it doesn't stretch the arteries out so that they can't work. And that's what happens when your blood pressure is way too high.
way too high. Wow. Okay. With stroke recovery, what would you say that it looks like in the weeks and months afterward?
One of the myths that you asked before was that people believe that you can only get better from a stroke over the first short period of time. You say a week, a month. The answer is no. And the way I describe it to the families I deal with is, as long as you're continuing to get better, you're going to get better. Once you stay the same for about 6 months, that's about where you're going to be.
Okay.
This could be years of improvement. And you get better with time and with therapies. And the therapies really push you to do things. They really, especially speech therapy, to relearn how to talk or how to move your mouth, swallow, all the things that we do. Those things are crucial. Moving your arms and legs, of course, stretching, things like that to reduce tone. People with a stroke get stiff. Their arms get stiff and they almost curl up.
Yeah.
So basically, we try to give everything to keep that movement as good as we can. So that's what we're trying to do with our patients. Know that you will get better and fight, especially early on. There was a study that said if patients who, after having a stroke, and rightfully so, are depressed, they do much worse. Because they don't do the therapy with the same gusto.
Yeah.
They don't go at it.
Okay.
And think about people who are working out. They don't have that drive. They're sort of predetermined, well, whatever happens, happens. The first few weeks are crucial in that big initial push. But the idea that you can get better for months, years later, is so important. It gives people so much more hope. And it's real. It's not us making that up.
Yeah, of course.
People have to know that they are going to continue to get better as long as they are getting better.
And so it's critical to maintain that motivation, and I'm sure having things like RUMC's stroke support group help, encourage that, because they can see other patients who have gone through something similar and how they've recovered, and maybe, different methods that they've tried that they can look into as well.
And the word yelling at someone, it'll sound not right, but I say, let's try.
Yeah.
A family member doesn't say it the way I would say it.
Yeah.
Family member would say to a husband or spouse or wife or mom or dad, say, and scream, you better start doing this. And sort of many a time you see people smile at them and they will try more.
Yeah.
You have to have that support group. It takes a village. If you think about someone with a stroke, there's an emergency room doctor, there's an emergency room nurse.
Of course.
There's a doctor, there's a neurologist, there's the therapist, there's the heart doctors. There's a whole village.
Yeah.
And the family is a major part of that village. The patient, obviously.
Yeah.
But the family is such a big part of that village. When you walk into a room, I could tell if someone's alone all day versus someone who has a relative next to them.
Of course.
And I sort of know, and it's sort of sad to say that the person who's got someone with them is going to do better with a similar kind of stroke or any medical condition.
Of course.
Because they're pushing them.
Yeah.
They're the ones who are saying, the physical therapist comes in, if someone says, I'm too tired today, the therapist will leave eventually. But with someone else in the room,
To push them.
and what we do in our hospital, people are allowed in the hospital all day. It's different than in the old days. People can come in different hours.
Yeah.
If you can get there with your loved one and
They need
push
that
them
support.
to do it.
Absolutely. They need that extra push of motivation to keep
And
going.
we all do. And
Yeah,
there's
that's
every
with
reason
everything.
to be depressed.
Of course.
There's every reason to be sad
It's
about
a traumatic event, absolutely. So to stay focused and stay motivated and know that there is hope is important. You
And there's
have
a
to
lot
hold
of
on to
hope.
that. Yeah.
People do, most of our patients do well. Sure, we hear the stories of people who don't do well, and sad to say, many people succumb to stroke. But there are so many people, so many more than that, who do well.
Yeah.
And with our early interventions, our therapies, time, family support groups that we see, it really helps people do better and do the best they can.
Absolutely. So let's wrap things up with leaving people with, if listeners walk away from this episode remembering one thing about stroke emergencies and recovery, what should it be?
Get to the hospital.
Yeah.
Get to the healthcare professionals. Don't make the decision on your own. Don't go to sleep.
Yes.
The worst thing you could do is go and say, I'm going to go to sleep and I'll be all right when I wake up in a few hours. Because by that time, most of the interventions we have are not there, and we're back to 1990 medicine. We're not up to the 2026 medicine that we have now.
Yeah.
And we want all of our patients to benefit from 2026 and beyond technology, not live in the past.
Well, thank you so much once again for joining me for another super informative episode. And if there's one key message to take away from discussion today, it is that during a stroke, time truly is brain, so acting fast can preserve not just life, but independence, memory, and quality of life, right? So from rapid emergency treatment to recovery and rehabilitation, stroke care doesn't end at the ER, and neither does support. At RUMC, patients have access to comprehensive stroke services, expert neurologists, and coordinated care designed to support recovery at every stage. So I want to thank you once again for guiding us through what happens during a stroke and what healing can really look like afterward. Your insights really help turn a frightening emergency into something that people can be better prepared for and know that there is hope on the other side. So remember, if you ever suspect a stroke, call 911 immediately and know that right here in our community, RUMC is ready with the expertise and compassion that patients truly deserve. So thank you for joining us for RUMC Connections. I'm your host, Meredith Gaskins. Until next time, stay informed, stay prepared, and take care of your brain health. For more information about Stroke Support Group, please visit rumcsi.org.